Hello, dear doctor, in Real Evidence in Endodontics. We are so happy and blessed to have you today in the first female in Real Evidence.
Oh, thank you so much. I'm very honored to be here.
Yes, the honor is mine, dear Prof, for your agreement to be with you. Okay, you can start, of course.
Brilliant. So thank you very much, everyone, to being here. We are going to start with this lecture about endodontic diagnosis. So I hope everybody can see that. Can we do the root canal treatments with normal conventional x-rays? Of course we can. For many years, like for me, for example, before 2008, I was doing all my root canal treatments with conventional x-rays. There are things that we do with the x-ray that we change the technique. We do paralleling technique and we do bisecting angle. And if you check the literature, there are so many studies, and those techniques, they can be used for different things. You can pre-measure your canal, for example, with the paralleling technique, and you can see the full length of a palatal root, for example, if you have difficulties, if it's a very long root, palatal or canine, you can do the bisecting angle technique. There are other things that you can do, which is the parallax technique or the cone shift. So, for example, if you want to see one root in particular, you have your GP point or you have your files and you want to see the length of the canals, but you don't know which canal you are. If you mesialize your tube of the X-ray, the furthest canal, the furthest root will follow that. So if you mesialize, the furthest root will go mesially in the X-ray. Same thing if you distalize, the furthest root, for example, the lingual or the palatal, will follow the tube. So for example, in extracted tooth, you think that the file is at the apex of the root, is the working length that you want. But in reality, you don't have the same thing. So the apex is not on the root apex. The canal apex is not the root apex. And that's why in this X-ray, you can see the file going out of the canal. But since 2008, there were cases that we were struggling quite a lot. And I started working with the CBCT, and I never looked back. Because the CBCT, if you combine it with the magnification, it gives you so much information. If you look in the CBCT and you find different canals, you can go with your magnification and find inside of the tooth, for example, 3 mesial canals in the lower molar or an awkward MB2 in the upper molar. And I'm amazed with magnification as well, because nowadays we can find lots of canals that we didn't know they existed. And I like this article because it happened to me. It changed completely the way I think. When I look on the X-ray, I say, there's probably something else from that X-ray. Perhaps on the CBCT, I will see more. And it's exactly what happens. So it changed completely the way you do your diagnosis nowadays if you are used to the CBCT technology. And the 3D is all about planes. So you have the volume that you can communicate with your patient, and you also have the axial view, the coronal view, and the sagittal view. The sagittal view is pretty much what the 2D offers to you, the conventional X-ray. However, you can remove any landmark that is in front of the root, so you can rotate and you can see those roots individually. And that's the whole idea of the 3D technology. And what do we use that for? There are several things that we can use the CBCT for. We use when we have any periapical pathology that we cannot see, or internal, external resorptions, trauma, complex trauma, fracture and crack. I would say crack is not really designed to see crack, because if the crack is in the early stage, you won't see that. If it's a separation, you will. Or if there is any bone loss in that direction of the crack, then you will see as well. But the crack itself, it may be that you won't be able to see. Complex root canal system. So if there are several canals that you don't know they exist, you will be able to see or to understand more with the CBCT. Untreated canals, if there is any risk of perforation, you are going in one direction and then eventually you notice that it's not exactly that way. So you can confirm on the CBCT where you are and find the canal where the canal is. Locate broken files is very useful because in the past we used to just go and try to remove the file. If you can't remove, you try to bypass. However, nowadays is a lot easier, and I'll show some cases about those topics. We'll discuss some cases and you see how easy it is with the CBCT when you understand where the file is. Extreme gag reflex is getting more and more common in our practice. So patients that cannot tolerate the X-ray, I think they heard about the CBCT and they want the CBCT to be taken prior to any treatment. And it's good because it's a trust as well from the patient. You can discuss everything beforehand. You don't need to stress that anxious patient unnecessarily. So you take the CBCT, you can give all the indications what to do and which kind of treatment you are planning. Target endodontics is when, for example, you did a root canal treatment and you don't know why it failed. And then you take a CBCT and you see that there is one canal that you missed. And in that scenario, you just go, if you did your case properly, you only go on that canal that is missing and treat that canal. And where is the pain coming from? Well, this is an interesting case that when we received the case, was like that. So the dentist saw this circular radiolucency, did the root canal treatment on the lateral, retreated the lateral, extracted the lateral, and then did the root canal treatment on a vital central. It was a bit short on the apex and it was referred to me to retreat that central because the dentist didn't have a clue what was going on. And when we took the scan, we could see that this radiolucency was completely out of the apex area, so was not related to the tooth at all. So the patient had treatment, retreatment, extractions, all unnecessarily. So it's important to see that beforehand so you can plan that correctly.
Yes.
Periapical pathology, several articles in the literature showing that CBCT is more sensitive than conventional methods with regards to detecting apical periodontitis, root resorption, and root fractures. Right, so when I started doing the CBCT, that was in 2008, and this was one of the first articles I saw. And I could understand that there was not much I could do without the CBCT in cases where I couldn't find where the apical pathology was. And that is because of the landmarks and the lots of interference from it on the conventional X-ray and the density of the bone as well, the zygoma, all of that. In a case like that, when the patient has pain in every single tooth, and you do all the tests possible that you can perform, like percussion, palpation, you check the periodontal pocketing, and you don't know where the pain is coming from. So let's start with what we can see then. This canal is a bit short. There is a little bit of extruded GP or sealer here, possible coronal leakage, silver points in those roots, a bit short over here and short over there, and perhaps something over here, but you don't know. Can you tell where the radiolucency is? I couldn't. So on the CBCT, that's a lot easier to see. So you know now that the second molar is probably the culprit of the pain, because all the others, they seem fine, but there is quite a large radiolucency apically on that tooth. So then it's a lot easier to communicate with your patient as well and explain that this tooth is the most obvious one, and we are going to start the retreatment with that one and monitor the pain to see if the pain will subside. Another case where the dentist did the root canal treatment was in the middle of the root canal treatment, and there was lots of pus coming from the tooth, and the dentist couldn't see anything, couldn't see any periradicular radiolucency. And they referred to me, and when we took the scan, look how big that radiolucency is. It's huge. So now we can understand what's going on. So it's a lot easier to talk to the patient, explain what's going on, and pre-warn the patient that we'll do the root canal treatment and monitor for the healing. And if it doesn't happen, then we are going to open and do a surgical procedure. But if you show that in advance, it's so much better rather than to do a root canal treatment that you told your patient, oh, just a simple root filling, and then it doesn't heal. So it's all about communication as well. And the root canal treatment, you can expect when you have those side lateral, on the radiolucency is more lateral, you can expect a lateral canal. What about this case? This case is a bridge, isn't it? So difficult when you have pain because you do percussion and vibrates the whole bridge, so your patient cannot tell exactly where the pain is coming from, and neither do you. So when you check this tooth, you can assume that there is a deep filling and a fiber post and a short root filling, and perhaps there is something here, or perhaps there is something there. You can't do any vitality test because the bridge is there, so there is no gingival recession. So any attempt to the sensibility test will be pretty difficult. But you can perhaps, with experience, you can follow the lamina dura. If you follow the lamina dura here, you will probably see that this tooth should be okay. And with this one, it stops there and it gets a bit more faded. Can you prove that? No, it's just like a hint for you. What will prove to you what's happening is the scan. So the scan will tell you which tooth is the problematic tooth, and then you can plan to start with that treatment. Same thing when you have impacted molars, wisdom tooth, and that is in front of the second molar, for example, or the premolar, like you have the canine is like impacted canine, so it's over the apex. So all of those cases, they get a bit more complicated. And the CBCT can show you a bit more what the anatomy of that tooth is. For example, the untreated canal, and where the radiolucency is, the curvature, and all of that for you to plan your case. What about if you did your root canal treatment? You think that root only has one canal, is pretty centered, and you say, but it's not healing. That's another thing. Instead of opening that tooth and start going buccally, palatally, and destroy the whole coronal part, take a scan. In this case, we took a scan. I don't have the scan to show, but we took a scan and we saw that the canal was more buccally, and we could go and do the root canal treatment over here, preserving the same access that we had done instead of extending too much and destroying that part. What about a lower tooth? Lower tooth, you expect that to have only one canal, although you know that in some cases you can expect different anatomies as well. But in a case that you have to dismount the crown, dismount the post, do the retreatment, it's a lot better if you can see that beforehand, what's going on. And yes, there is another extra canal here. So, and that is the problem that you still have residual bacteria. Resorption. CBCT is a reliable and valid method of detection resorption lesions as well. And if you saw my post about this case, I want to go in more details because this case is quite complex. And I really like it because when you see, you don't know if it's an internal or external resorptions, although you know by the books that if it's an internal resorption, you don't see the line of the canal. So pretty much over here, you think it's an internal resorption, and it is an internal resorption. But it could be an external that had internalized already. And that's where you feel that you don't know how to do that treatment plan. So in this case, for example, there is like a separated file over there. There is the root filling and the internal resorption. How would you approach that? Well, think about where the other canal is, the canal that it fuses into one. That is your aim. You want to come here. So if you want to come here, then you have the canal that is a bit more in straight line. That is the canal that you need to prepare first. Because if you go on the curved canal first, there is a high chance that you will ledge it even more. And that's why the previous dentist couldn't do the root canal treatment, because he was already ledging it. So when you go on this straight canal, it's a lot easier for you to navigate into the canal and do your glide path and then prepare your canal. Once that is done, then you can prepare the other canal. It's a lot safer to do that way. And another thing that you need to see on that tooth is this radiolucency here. It's very weird, isn't it, this radiolucency, because you think that there is a possible crack in this tooth, and it could be a crack in this tooth, but realistically, if you had a crack in this tooth, I would have expected to have a bit more radiolucency over here, and not only on the palate, on the furcation area. So in that scenario, I think about a lateral canal. And that's exactly what it is a lateral canal if you see the other X-ray. What about complex root canal systems? You can see several canals nowadays, like this article here. Most of the times they fuse into one. However, there are cases that you see lots of separated apices as well. So you need to be careful, because you never know if they join or not. Then you need to prepare them all. A case that we always show what is successful, and this is a failure. So I did this root canal treatment, and I was so happy that I had done 3 canals in the mesial root. However, 3 canals in a mesial root when there is a curvature is something tricky, because it may crack. And that's exactly what happened. I can't see the crack, as I told you. It's not possible to see the crack unless it's a fracture, but I can see the 3 mesial canals, the distal and the palatal. They are absolutely fine, those mesial canals. And then this is the root I told you. Because of this double curvature, any file, and this case was prior to the 04 taper. Nowadays, I use the 04 taper. I prefer that, and mainly because of those cases. You don't know how much stress you can put into those roots. So in this case, we had that double curvature and the root cracked, and now is the time to open and do a root apsectomy. So fractures and crack, as I said, the CBCT is more accurate than conventional x-rays, and this is for root fractures. But this case is an interesting case because it looks like there is a post over here, or something like a post, because you can see the cement in the walls, and the root filling. But is there anything else that you can see? I can pretty much see a little bit of bone loss on the distal. Can I prove anything? No. Let's take a scan and see if it's a periodontal problem or something else. And that's when you can see the fracture line. Can you see that? So that proves that this tooth is fractured. Same thing about trauma. When you have a trauma, I told you that you can expect to have radiolucency. However, if it's a trauma, that fracture will come before the infection. And if it comes before the infection, you don't see any bone loss, but you see the fracture line. What about when you have a bridge? Well, when you have a bridge, in this case, it's also very difficult to understand if there is a crack or not on the tooth, unless there is a deep periodontal pocket or something like a swelling. And even then, you don't know exactly if it's a fracture or not, unless unless you see the fracture under the crown. But when you take the CBCT, you can see the fracture line across. It's fractured. But not every case is about fracture. So we saw in our textbooks that J-shaped lesions are related to cracks. Well, they can be. And I like to say that you need to flag that out when you see something like that. But nowadays, what we tend to do is we tend to explore the tooth. If the patient is on board with us, if you say to the patient, listen, there is a chance this tooth is cracked, but if you want to save the tooth, I'll be more than happy to explore it further under the microscope. Patient normally, when they want to save the tooth, if the cost is not an issue, they prefer to do that. So, and that was the case. I accessed this tooth and I could see a distal crack. And when I saw the distal crack, I said, I think this tooth is completely cracked. But when I went inside, it was not. It was not going, because on the CBCT, you can see that on the distal area here, there was no deep periodontal pocket. There was no bone loss. It was more related to the mid-third toward the apical third. And when we did the root canal treatment, it healed beautifully, and now is the time to put a crown. I like to do the biomimetics and follow that when I do my composite. In every case nowadays, we do the composite core. Some of the cases I showed are pretty old cases, so you can see a little bit of amalgam left. But nowadays, we tend to put composites in all of our cases. And mainly, we go deeper into the canal, about 3 millimeters, to protect that area with the composite. What about if you are accessing the tooth and you can't find the canal? You think that you are in the middle of the root because it looks like on the x-ray, but you can't find the canal. Well, it's good to take a scan because you are probably going towards a completely different area. And if you carry on, if you persevere, you end up perforating the root. So in this case, when you take the scan, you can see exactly where the canal is, and it's a lot easier for you to correct at that time before you perforate. A case that, again, you need to get the patient on board and everything needs to be quite good for you to plan your case. In this case, there was lots of caries compromising the ferrule of that tooth. You can see the post is pretty centered apparently, but no root filling over here, or just defective. A bit of radiolucency, hypercementosis perhaps. But it's all about the combination in that case. So the patient didn't want to kind of persevere, because when we took a scan, we could see that the post was completely off. And that's exactly what it is. So there was a perforation buccally. To save that tooth, we would have to remove everything, repair, do a crown lengthening on this tooth, repair the perforation, do the root canal treatment, re-prepare, and then do the crown. And cost-wise, it was quite a lot for that patient, and the patient decided to go for an implant instead. But it's good that you pay attention that it's not that the post looks straightening in the middle, that it will be like that. I love those two cases because they have exactly the same symptoms. It's so interesting. The patient came with swelling, buccal swelling, and no deep periodontal pocket. And when you see a case like that, you say, well, okay, it's a J-shaped lesion and it could be cracked. The other one is short root filling. So let's have a look on them separately. This tooth was treated. Possibly you have some coronal leakage over here, defective root filling, short root filling, bit of extruded sealer. You can't really tell whether there is radiolucency or not, but there is a buccal swelling. I said to the patient, I'm quite convinced this tooth is cracked. And she said to me, oh, Dani, I don't want to lose that tooth. Is there any way you can save that tooth? And I said, well, I can take a scan. And I took the scan and I saw the radiolucency, like a loss of buccal bone, not as much apical radiolucency on the mesial root, periradicular radiolucency on the distal though, but not on the meso. The meso, there was loss of the cervical, the cortical bone cervically and mid-third. Why couldn't I probe that tooth? Perhaps a long epithelium or something like that, but I was a bit puzzled because I truly believed this tooth was cracked. And she said to me, can you do something else? And I said, okay, I can open a flap. I was curious as well, and I said, I'll do that. So I opened a flap, and I couldn't see any crack. And I was like, okay, maybe I got that wrong. Maybe it's not cracked. But then I noticed that there was granulation tissue over here. And if there is granulation tissue over here, there is something. And when I took the granulation tissue, and I didn't do any osteotomy, when I removed it, I could see the 2 cracks.
Yes.
And look at how thick the cortical bone is, and that's why I couldn't probe. So it was an interesting case. Could I have saved that tooth? Yes, I could, perhaps with extracting that root, but realistically, with that occlusion, I don't think this tooth would have been for too long in her mouth. What about this one? Well, this one is the one you probably say, oh, is fractured. Or most of my students, when they come on the leave the university or they are on the undergrad, they say, oh, it's cracked because it's a J-shaped lesion. It's straight away. However, if you see on the scan, there is a very, very small cortical line over here. Remember, we couldn't probe. And there is lots of scaffolding for the bone to grow if it's not cracked. So in that scenario, I said to the patient, shall we just treat it? I think there is a good chance this tooth is going to heal. And it did. And most of the time, when you see that radiolucency going up that way, is because there is a lateral canal. What about this one? The dentist treated the tooth, retreated the tooth, and asked me to do an apsectomy because the tooth was still infected and failing. There is quite a large radiolucency and a very large defect. But when you take this, I didn't even take this scan in that case, to be honest. I saw clinically, and there was loss of the gingiva and the bone on lingual. The tooth was grade 3 mobile already. And the question here is not if we can save the tooth or not. The question here is why that tooth is in that situation. And if you check, there is a little bit of enamel missing on that tooth. Probably is a tooth wear or chip. I think it was fractured. But one thing that everybody missed in this case was the pierce. So there was a tongue pierce, and the patient used to play with this tongue pierce, moving the tongue forward and forcing this tooth buccally. So this tooth now was completely compromised, like the whole support was gone. What about this case? It was referred to me to treat the 6. The 6 was necrotic. But the dentist was a bit uncomfortable with the whole case because the patient was having the symptoms was like a palpitic tooth, heat, cold. It was like very throbby, pulsating, temperature. And then he said to me, I think it's the 5. But what he missed was the decay or caries, the distal caries on the 7. And this is because of the 8 leaning towards that 7. Another interesting case of fracture, like the tooth fractured, and apologies for the blurred image over here, but there was lots of granulation tissue and it was quite a mess. And the dentist referred for me to see if I could save it, although he thought that I would say that it needs to be extracted. When I took this scan, I could see that the fracture line was in a bevel and it was not infraosseous, and I could just do a gingivectomy, could expose this tooth to a small crown lengthening, and that's exactly what I did. I put the titanium parapost, it can be a fiber post as well, there's no problem, and did a composite core build-up for the dentist to do a crown. Interesting case, a 16 years old boy So he came to me, and there was no history of trauma. There was no orthodontic treatment, nothing. But he had this tooth with no filling, quite a rigid tooth with a periradicular radiolucency, and also this radiolucency here, which we didn't know exactly. It looked like external cervical resorption, but we were not entirely sure. And when we took this scan, look how different that is. It's completely different than anatomy. So we proceeded with the root canal treatment, and I attempted the bioceramic over there. But I was not that happy with the bioceramic, although I could go out of the root, but I was not that happy. I waited because he's a young patient, was a long appointment for him. And it did heal. After 6 months, we took another scan because there was a little bit of problem interdentally. And the cortical bone is intact over there, and it's just over here. So we tried a little bit thicker, removing. Remember, we had to go through all those lines here. Everything. We had to pretty much reconstruct that tooth in bioceramic. And now we are just waiting, and hopefully it will heal. Perhaps we'll have to open, hopefully not, but if we have to open, it's just to a recontour of that tooth, but hopefully we won't need that. The patient is absolutely fine. The tooth is completely asymptomatic, back into function, so I think it's okay.
Okay, dear Prof, do you fill the space with bioceramic material after doing a flap or under magnification? You fill the complete space?
Yes. If I have to, I didn't do any flap in this case. I went through.
You just do orthograde cavity?
Orthograde. Yes, orthograde. So what we did, because we didn't want to destroy much of this bone because it was quite thick, we went through the access cavity. I just extended the access cavity a little bit more, preserving the ridge over there, and did like a tunnel.
Okay, it was easy to fill this cavity.
That's why it was not easy. The first attempt we tried, and it was difficult already. The second attempt was a lot better because the first attempt I had dried completely that area, so it was not that mucky inside. So it was a lot easier on the second attempt. So that's why we decided to try again. Because in the first attempt, when I did, I said, although it looked all right, I was not that pleased. But I said, well, let's give it time. And he's a young patient. Let's wait. It didn't heal. We opened up again, and we did just this tunnel again, not the root filling, because everything had healed or it was healing nicely. So we didn't have to touch. We didn't even remove the composite that was covering the canal, so we didn't have any recontamination. What about when you have two roots so close and inside of the same area? Are you going to treat both of them? Well, that's when you need to do all of your tests, and make sure you do that accurately, because it will be a shame to open a tooth that doesn't need to be treated, and that's exactly this case. So just the central needed a root canal treatment and not the lateral. But it's quite common to see, oh, there is a large radiolucency, two roots inside of it, let's treat both of them, and they just access both of them unnecessarily. So if you are in doubt, treat one, mainly in young patients, treat one, the most obvious one. If you have like, oh, this vitality is inconclusive, this sensibility is inconclusive, then treat the obvious one first and then monitor. When you have radiolucency more like interdentally, in this case, we could see that this was the problematic tooth and the root filling was more obvious. But what happens to that tooth when it's a lot larger and everything is so difficult for you to check? So, and we are normally a bit scared of large radiolucencies. So pay attention. Of course, this tooth has a crown, is more likely to be the problematic one. There is an apical radiolucency, again, more likely. but you think that this is growing and is moving the root a little bit, so it could be malignant. Yes, it could be. However, I would say as I always say, go for the obvious thing first. So go treat the canal, monitor. If it's healing, amazing. If it's not, then it's time to refer. And if you go, unless there is something on the medical history or something and that's why a comprehensive diagnosis is important. Checking the medical history, hereditary history, all of that, so you can understand if there is anything else involved in that situation here. But when you can't find any other reason, then go for the root canal treatment because it is going to heal. I wouldn't advise to open for surgery afterwards if it doesn't heal. I would recommend the referral to the maxillofacial surgeons to explore if that is malignant or not. What about this one? Well, the root canal, it was a trauma case. The root canal treatment was done. There was like an extruded material, and I believe that it was apically extruded, and once that area started to grow, then it moved that more coronally. The treatment was, this lateral was completely necrotic. We took a scan and we saw the radiolucency quite large.
Yeah.
The canine was a bit inconclusive as well. The patient sometimes felt it, sometimes didn't. So I said, let's just wait. I won't treat that. I will go just for the obvious ones. And did the whole retreatment of the one or the central, and then treat the lateral. And at the same time, I opened up for the surgery and did a small decompression, removing that material that I didn't know what it was. So I decided to remove it. I haven't done at that time, it was quite a long route, and the patient was quite young as well. And I decided to do just a decompression at that time. And it did work. I didn't put any grafting in that case. So there are things that you can do that it don't need to be very complex. But decompression worked for so many years. So it's not every case that you need to follow the books and do everything according to. Each case is different. So I think you need to understand several techniques, several cases for you to know which of those techniques you are going to choose.
Yes. I think the clinical experience also play a very big role in our job.
Absolutely, I agree. And another thing that I like to say is that the decision-making depends on the experience of the dentist, like you said, but also in the environment in which they work. Because if they work in an environment that can provide a microscope or something, a bioceramic material, or then it is a lot difficult for you to do complex cases.
Yes.
CBCT, for example. So there are limitations. This case, for example, I did when I was still doing prosthodontics, like full mouth rehab and all of that. I retired and I'm only doing endodontics now. But at that time, I didn't have the CBCT. And what I knew at that time was to remove the crown, remove the post, and retreat the canal. It was the obvious thing to do. Perhaps if I had done this case now, I would have gone for the surgical because there was no coronal leakage in that tooth. The crown was nil, the post was nil, but I didn't know how to do that differently. The tooth was infected, swelling, pain. But perhaps nowadays I would have had opened that tooth for a surgical procedure and do an apsectomy instead of doing an orthograde retreatment, which is a lot more complex, to be honest. I hope you have enjoyed that. Thank you so much for staying.